Good day, and welcome back to our training on advanced geriatric care for advanced practice nursing. In the previous video, we explained what reduced physiological reserve means in practice. We described why presentations are atypical in older adults. We also identified what vulnerability and functional decline look like clinically. Then, we said that rather than asking, "What disease is this?" advanced geriatric care asks, "What has changed? Why is this dangerous for this patient? And what is likely to happen next?"
By the end of this session, the learner will be able to 1. Define geriatric clinical reasoning and differentiate it from task-based care. 2. Explain why disease-centered reasoning is insufficient in older adults with multimorbidity and reduced reserve. 3. Apply the principle of change from baseline when assessing older adults. 4. Identify functional and cognitive changes as early indicators of deterioration. 5. Describe safe reasoning strategies under uncertainty, including early escalation and avoidance of common cognitive errors. We will start with knowing what geriatric clinical reasoning is. Geriatric clinical reasoning is the intentional, structured thinking process used to interpret changes in older adults and guide safe clinical action. Unlike younger patients, older adults often do not present with a clear symptom patterns, strong physiological alarms, or single disease trajectories. The aging body often whispers rather than shouts when something is wrong. Advanced practitioners must therefore listen for subtle decline, small functional changes, caregiver concerns, and inconsistencies from baseline. Let's look at task-based care versus reasoning-based care. Task-based care focuses on what to do, such as to administer medications, record observations, follow instructions. For example, vitals are normal, continue monitoring. Whereas the reasoning-based care focuses on why things are happening and what might happen next. For example, vitals are normal, but the patient is newly confused and weaker. This is high risk. Therefore, advanced practice demands reasoning-based care. Next, we will see why disease-focused reasoning fails in older adults. Traditional reasoning assumes one problem at a time, clear symptom-disease links, and strong compensatory responses. But in older adults, multiple conditions interact. Compensation is limited. Deterioration may be rapid and silent. This mismatch explains delayed diagnosis and preventable harm. Let's move ahead to see what change from baseline means. Baseline includes the patient's usual mobility, cognition, independence, appetite, communication. Any deviation, no matter how small, must be taken seriously. If they are not themselves, something is wrong. Next is how functional and cognitive change indicate deterioration. Function and cognition are medical data, not background information. Examples: new difficulty standing. This may be caused by infection, dehydration, or medication effect. Also, new confusion. This may be caused by an infection, metabolic disturbance, or drug toxicity, and ignoring these signs delays intervention. Moving ahead is how advanced practitioners reason under uncertainty. Advanced geriatric practice requires action before certainty. Let's see the key principles. 1. Act on risk, not proof. 2. Escalate early in vulnerable patients. 3. Reassess frequently. Just know that waiting for certainty often causes harm. Finally, Let's see the cognitive errors in geriatric reasoning. Common errors include ageism, this is normal for age, anchoring on one diagnosis, over-reliance on tests, ignoring caregiver input. Advanced practitioners must actively guard against these errors. We've come to the end of this session. In summary, geriatric clinical reasoning is the structured process of detecting subtle changes in older adults and making timely, risk-based decisions to ensure safe care. We've come to the end of this session. See you in the next video. Bye for now.